our next student, Mehar Birjal. He came to us as a fifth-year medical student at University College London, and his background included research heavily focused already on the aortic root. Since he was especially interested in advancing the field of imaging to aid clinical diagnosis in the context of Marfan syndrome and Loeys-Dietz syndrome, he was delighted to be accepted into the Royal Brompton Hospital Cardiac Radiology Department, supervised by Dr Mirsadraee. There he spent weeks measuring and analyzing data from the Royal Brompton's collection of CT scans from 500 Marfan patients. He's here to tell us about his preliminary analysis of this work in progress. Mehar, over to you.
Thank you very much for the introduction, Dr. Child. Hi, my name is Mehar Birjal, and I'm a final year medical student at University College London. And I'm here to speak to you about the research that I did as part of the Bryan Adams Memorial Studentship over summer. I started this project around 2 months ago, and although it's still ongoing, I wanted to share my results with you so far. AI is a new hot topic that everyone has been talking about, and this project is about using AI to create a way to predict aortic events such as dissection. It's a bit of background that my colleague previously has already covered. Marfan syndrome is the most common heritable form of thoracic aortic disease. It can be observed in numbers as high as around 1 in 3,000 in Europe, and it can be attributed to mutations in the fibrillin-1 gene, which affect the protein fibrillin-1, a protein responsible for structural integrity of structures such as skin, ligaments, and also the elastic fibers found in blood vessels. Although Marfan syndrome may have manifestations in multiple organ systems, aortic root involvement is actually the primary concern. Aortic dissection or aneurysm is the hallmark of Marfan syndrome. Advancements
Sorry to interrupt, Mehar. It's Jo. Your slides aren't in presenter mode, so we can see all the notes and all the other slides and things.
Oh,
you might
really?
try resharing.
I see. Sorry.
So they're coming up quite small. That's it. Perfect. Thank you.
Okay. Apologies, everyone. Advancements in management, including earlier diagnosis, surveillance, medical and surgical management. Advancements in these have resulted in life expectancy in Marfan patients nearing that of the general population. So I wanted to play a video now just to demonstrate how dissection happens. So blood pumping against a weakened aortic wall can lead to aortic dissection, which may or may not occur with an aneurysm present. Most commonly, aortic dissection begins with damage to the inner layer of the aortic wall, the intima. Blood then moves through the break in the intima into the space in between it and the next outermost layer of the wall, the media. This creates a false channel that we can see here and means that the flow of blood is completely disrupted and the risk of rupture is heightened. So I wanted to explore this in a bit more detail. So it's clear that dissection results from a particular moment in time where the pressure of the blood inside the wall exceeds the strength of the inner layer of the aortic wall. And this moment in time will lead to the wall to dissect. This is due to factors that are beyond simply the aortic wall expanding. This includes thinning of the aortic wall's middle layer, damage to elastic fibers, and also loss of muscular cells within the aortic wall. This is well shown in mice models and slides that have been analyzed in the lab. So if we look at the top left at images A and B, we can see mice that do not have the fibrillin-1 mutation, and we can see what the aortic wall looks like. So we can see that the elastic fibers are tightly packed and well organized here and here, compared to mice that have the fibrillin-1 gene mutation. And we can see that the fibers are loose and scattered, and the structure is mostly gone. This means that the aorta is weaker and is likely more prone to aneurysm and dissection. I also wanted to highlight the current recommendations. So the European Society of Cardiology recently published guidelines this year, demonstrating the current gold standard of routine surveillance, including when to intervene and treat. These guidelines state that all patients should receive a baseline CT or MRI scan, regardless of their aortic root diameter. It also states that the patients should receive an echocardiogram every year up to a diameter of 45 millimeters. Once this diameter exceeds 45 millimeters, but is still under 50 millimeters, they should receive an echocardiogram every 6 to 12 months. However, if there are risk factors present, the guidelines state that patients should receive an echocardiogram every 6 months rather than every year. Risk factors may include pregnancy or uncontrolled hypertension. If this diameter then exceeds 45 millimeters, these patients should be considered for surgery. And if any patient with Marfan syndrome has an aortic root diameter that is discovered to exceed 50 millimeters, they should be referred for surgery as well. So, although research shows that the risk of an aortic event like dissection does indeed increase with aortic diameter, other research shows that actually dissection can occur in diameters that are less than those discussed in the current guidelines. And this warrants further exploration in attempting to predict dissection in ways that are less arbitrary, such as purely based on diameter. It means that accurate risk prediction is essential and that size criteria may offer a framework, but it does not address the full complexity of predicting aortic dissection. I also wanted to highlight what these guidelines are based on. So a physician called Laplace discovered this law that states that the tension in the wall of a cylinder is determined by the radius of the cylinder, the pressure inside the cylinder, and also the wall thickness of the cylinder. So although these guidelines do take into account the radius, i.e. the diameter of the aorta, they do not take into account the thickness of the wall. And this is where we thought we could shift our focus to. And in fact, research does show that even if there is not significant dilation, but the aortic wall is thinner in studies that have looked at samples of aortic walls that have dissected, these studies do show that thinner aortic walls indicate a higher risk of dissection. So where does AI come into all of this? It can be challenging to visualize the aortic wall on a CT scan. And although we now have MRI scans which can show the aortic wall beautifully, CT is much more widely available and it can be implemented into most centers. But since we can't visualize the aortic wall as well, it emphasizes the need for a tool that can better assess the aortic wall than just the human eye alone. So these are some general uses of AI in radiology that are up and coming. And although I won't go into all of them, I want to shift your focus to segmentation, which refers to highlighting and separating different parts of the image. And this segmentation technique was developed by TerraRecon, and this is what we used in our study. So I'll get into segmentation a bit more in just a moment, but just to highlight the aims of our study so far. So our aims were to analyze the utility of AI in using segmentation to predict aortic wall volume from CT scans of the aorta and compare this between a cohort of Marfan patients to matched controls. and to see whether there was a difference there. And we also, so far, have also compared whether this aortic wall volume can predict whether a patient was treated. So on the left here, we can see what the CT scans that I analyzed look like. So on the top left is a transverse plane where we sliced the scan across the yellow plane here. And then here we have the coronal and the sagittal planes. So we sliced the scan downwards in the pink and the blue sections. We then applied the artificial intelligence model, and this is what we got. So this is the aorta after segmentation. So not the aorta, sorry, the aortic wall. So what this has done is it has removed the blood inside the aorta, and it has removed all the organs surrounding the aorta. And all it's left is the actual wall of the aorta itself. So the first step was purely segmentation. We then moved on to the second step here, where I sliced the aorta at this line here, seen on the right. And this meant that I isolated the thoracic aorta alone, meaning the aorta, the part of the aorta found in the chest wall and not below it. I then isolated this further, which I'll show in a second. So I isolated this further. So I sliced the aortic root, which is this part here at this line. And then I finally, I then calculated the volume of this section, and this gave me the volume of the thoracic aortic wall. And then next, I cut the image here, and I calculated the volume, and this gave me the volume of the aortic wall of just the ascending aorta. And I want to go back to the slide, which shows what the segmentation process actually looked like. Okay, and it also highlights why I chose to measure the aortic wall volume as a whole, rather than the thickness of the aortic wall at certain points. So while thickness itself can provide localized information, total volume actually accounts for the total space and allows us to capture, both the width and the length of the wall volume. And the AI has demonstrated this beautifully here. It shows that the wall is actually thicker in this part of the slice, but is not as thick on this part. So if we were to just measure isolated parts, we would see that the wall is really thin in this part, and this would give us a false impression because the wall is actually thicker here. So that's why we chose to measure aortic wall volume. Moving on to results. So this table is just a summary of some of the data that I collected. So I measured the volume of the ascending and the thoracic aorta in both cohorts across 36 patients in the Marfan cohort and 33 patients in the control cohort. We then performed a statistical analysis on this data, and initially we did not see any difference between the two groups. Although the mean aortic wall volume was higher in the Marfan group compared to the control group for both the thoracic and the ascending aorta, these differences were not shown to be statistically different. However, we realized that taller individuals are likely to have bigger aortas and therefore bigger wall volumes, and that this may actually affect our results by not allowing us to truly measure the difference between the two cohorts alone. So then we obtained data on height, body surface area, and total aortic volume, and we divided our aortic wall measurements by these values, and this is what we got. So we saw that there was no difference between the two groups by accounting for height and body surface area alone. However, when we adjusted for total aortic volume, we saw a clear difference in aortic wall volume between the two groups. So we saw that So we saw that the ascending wall and the thoracic wall, when indexed by the total aortic volume, there was actually a clear difference between the two groups. And the control group had a higher volume compared to the Marfan's group. And we can say that they were significantly different. There was no significant association between thoracic and ascending aortic wall volume, and we saw that this could not predict whether patients received treatment or not. Treatment includes patients receiving a personalized external aortic root support, mitral valve repair, aortic arch repair, or aortic root replacement. So to conclude, my team and I established that thoracic aortic wall volume is greater in Marfan's patients when compared to those without Marfan syndrome after adjusting for the size of the aorta. And the same goes for the ascending aorta. Marfan patients tend to have higher wall volumes here too after adjustment. However, aortic wall volume did not predict whether patients received treatment. So this could be significant as we can use our results to establish whether a difference in aortic wall volumes actually resulted in a higher risk of aortic events, but further work is still required to assess this. So future directions include the following. So we want to see whether the difference between the two groups actually predicted dissection. We want to see whether wall volumes changed over time and whether this affected dissection. And we'd also want to include more patients potentially in the future, as this could give the study more statistical power. Thank you, everyone. And I'd like to welcome any questions, and I'd also like to thank Dr. Anne Child and also the rest of the team at the Marfan Trust. Thank you.
Thank you very much, Mehar. Could I ask a quick question? Your matched controls, do they also have Marfan syndrome, or are these other aneurysm patients who don't have Marfan syndrome, or are they normal people?
Yes, so the control cohort are patients without Marfan syndrome, and they are patients that received a one single CT aorta scan.
I understand. Okay, thank you very much.